My name's Dr. Simon Friley, consultant in clinical neurophysiology. Welcome back to the channel. In this video, I'm going to be talking about childhood absence epilepsies. If you haven't already done so, please do hit the subscribe button down below and help support the channel in that way. So first of all, childhood absence epilepsies are quite common. They make up about 15% of the childhood epilepsies. They occur in previously normally developing children and usually between the ages of about 4 and 10, peaking about 6 or 7, and it tends to affect girls more than the boys. In terms of how they express themselves, it's the absence, staring vacant spells. Now, if you're a parent who's trying to work out perhaps whether or not your child is just daydreaming or having absence epilepsy events, this slide will hopefully help clarify what we as clinicians are looking for. So first of all, is there an abrupt onset? Is it something that happens just like that? Or is it something that happens more gradually? That's more of the daydreaming type of activities. Now, this also occurs regardless of activity too. So if a child's being bored in school, that's one thing, but if they're actually zoning out pretty abruptly whilst they're doing something that they are engaged with, something that they're interested in, then that also favours this being more of an epileptic absence. It's not responsive to stimulation, so if you go and tap them on the shoulder or on the hand or whatever, they will not snap out of it. And they can of course have lots of them, and so it used to be called pycnolepsy from the Greek pyknos, which means many. So they're having many of these attacks. They can sometimes be several, to even tens, even hundreds of these occurring a day. So this is super disruptive to kids, particularly in the school settings, and often it's the teachers who notice these things. Now, in terms of what the kids are doing whilst they're being vacant, so usually there's a motor arrest, but and that means that they just stop what they're doing, behavioural arrest, but they may be having some rhythmical eye blinking or some lip smacking or some other form of automatisms too. In terms of what happens when they are coming back into the zone, so often they are resuming what they were doing beforehand, as if they hadn't ceased what they were doing, and that's in contrast to daydreaming kids who will just gradually come back into the room, as it were, and probably not pick up what they were doing before. And of course, hyperventilation is a marked activator. Sometimes we need to start thinking about, could this be something else rather than childhood absence epilepsy? And age is a very important factor here. If it's under the age of 4 or over the age of 10, then we need to start thinking about other things. If there's abnormal development, or from clinical examination, the doctor is finding something which is not quite right, then that points away from this. Also, if there's a low frequency of these absences, they'll also point away. The generalized tonic-clonic seizures or myoclonic jerks, again, one needs to start thinking about other entities. In terms of tests, obviously there's the start of this, which is the clinical evaluation, where the history is taken, all these types of absence patterns are teased out, and of course there's a neurological examination as well, hyperventilation, and following that usually there will be an EEG, which is very important in terms of supporting the diagnosis. Imaging doesn't tend to be so important with this. If an MRI is done for whatever reason, it should be normal. In terms of the EEG, we are looking for a normal background or a background with posterior slowing, which occurs in about a third of these children. The discharges will occur in bursts of about 3 per second. They are enhanced during sleep and by sleep deprivation. Hyperventilation is a trigger and certainly an enhancer of these discharges, and for a small proportion there will be photic sensitivity, so they'll be sensitive to flashing lights. When a seizure does occur, they should be regular, long discharges of about 3 Hertz with an abrupt onset, and usually there will be a fairly abrupt offset to it as well. But there's a whole spectrum of different patterns which can all still fit within the same diagnosis. So for the neurophysiologists, for the neurology residents, paediatricians out there, this slide's a little bit more for you rather than for parents. So there are different EEG and syndrome criteria which we can apply to delineate typical childhood absence epilepsy from perhaps atypical or perhaps something else. And so we have the ILAE, the International League Against Epilepsy, which has a slightly broader definition compared to the Panayotopoulos ones, which were produced about a decade later. And there are more exclusion criteria than the Panayotopoulos ones. For example, polyspikings, discharges less than 4 seconds being predominant, and things like that. And if one has a look over here on their breakdown of their particular series of patients where they applied the 2 criteria to their cohort of about 45 kids, actually the ILE, which is broader, had more kids diagnosed in the childhood absence epilepsy, but if they were recategorized according to the Panayotopoulos ones, quite a few of those actually ended up being JAEs, juvenile absence epilepsies, and that is actually important in terms of trying to work out what the prognosis would be. So in terms of treatment, there was a very famous study, 2010, looked at about 453 children with absence-only childhood absence epilepsy, and they had a look at the efficacy and the side effects of a variety of commonly used anti-epileptic medications. And it turns out that ethosuximide was the best choice in terms of efficacy and also in terms of side effect profile. Sodium valproate was just as good in terms of how good it was at controlling the absences, but actually it tended to have more side effects in the longer term in terms of attention deficiency issues and weight gain as well. Lamotrigine was the least efficacious of the lots. Now, epilepsy, as we all know, can be quite complex, and what works for one person may not work for another person, so it may have an insufficient effect for a variety of reasons, which we'll come back to. Not all patients will benefit from having ethosuximide. Children who may have generalized tonic-clonic seizures may need to have a different medication, and of course side effect profiles are different for different kids in terms of what they can tolerate. Now, sometimes I'm accused of being a pill pusher, so I do want to mention that there certainly is a role for a ketogenic diet in terms of seizure control, and whichever way you want to try and control this, the overall seizure control, depending on the series that you look at, is somewhere between 75 and 90%, whether in terms of first, second, or combination therapies for how we dispense these anti-epileptic medications. On a slightly positive side as well, because we will talk about remission and recurrences and so on in a moment, there may also be a disease-modifying effect. Taking ethosuximide, it may help to reduce the chance of this carrying on in the future. So in terms of remission, usually this epilepsy is very much age linked and often will go into remission by the age of about 10 to 14, which means that children are on medications for just a couple of years really before we can start thinking about weaning them off. Now, in terms of the rates of remission, we're talking anywhere between about 55 to 95%, and that really does depend on how you define them to begin with. And childhood absence epilepsy, which may have generalized tonic-clonic seizures as part of it, or if there's a family history of generalized tonic-clonic seizures in their epilepsies, or if there's myoclonic components, may have a lower chance of going into remission. Similarly, if they have absence status epilepticus, or if there are atypical EEG features, which we'll dive into in a moment, then again, the remission rates are reduced. About 15% of kids with childhood absence epilepsy will go on to have a phenotype and expression of epilepsy which is in keeping with juvenile myoclonic epilepsy, and therefore it's important really to try and work out which kids have a pure childhood absence epilepsy which they'll grow out of, and those which they may not necessarily grow out of. Now, remission aside, there are other developmental issues that need to be addressed as well. So whether or not the epilepsy remits, there can still be issues with attention longer term, with reduced attention, issues with behavior, issues with cognition, and don't forget, these are kids in very formative years who are having tens, if not hundreds, of absences a day. This can be super disruptive. There can be emotional issues as well, and so the overall outcome in terms of the well-being and well-roundedness of children who have had to go through this is at risk. And so these have to be looked at holistically in terms of sorting all of these different issues out, quite apart from the epilepsy itself. In terms of the EEG features, which may predict a less favourable treatment response and treatment outcome, are things such as background slowing being present, if the spike wave discharges are slower than 3 per second, if the discharges are irregular. Usually they are very, very regular things, but if they're irregular, then that can be a negative feature. If there's photosensitivity, again, that might be a negative feature. And absences which last less than 7.5 seconds, again, a negative predictor for treatment response. Now, I've talked about this in the previous video. Epilepsy is not one condition. Even if you try and tightly tidy up how you define it clinically. Now, we know that there are genetic elements to childhood absence epilepsy. About 20% have a family history, but our efforts thus far are quite limited really in terms of identifying exactly which genes are involved, which genes are responsible. Now, we know that there are different responses to the medications, and in fact, in terms of the genes that we do know, we know that GABA, so these channels which are involved with inhibition, or T-type calcium channels, are implicated within that of the dysfunction of channels which predispose to absence epilepsy. But under the age of about 10% have glucose transport 1 deficiency, which is a different entity to the others. And in fact, we know that those types of absence epilepsies are actually made worse by fasting, worse in the mornings for that reason, and also can occur post-exercise. So it's important to try and differentiate the actual genetic cause underlying it. And within the ion channels which are responsible, we know that how they are made up, their polymorphisms, how they're encoded, that can actually now impact on the efficacy of different treatments. So I'll spare you the alphabet soup because I can't even say it, but some of these polymorphisms will actually be less responsive to ethosuximide than other polymorphisms. And apart from that, genetic variants in how the body deals with the medications will also play a part as well. So we know that not only are there different ion channels involved, but the way that the genes that encode the ion channels are expressed and how they formulate those ion channels will have a different profile in terms of the treatment and the treatment outcomes. So it's far more complex than what meets the eye when we see a child having typical absences and a typical EEG. There may still be significant genetic differences which will alter how we should be treating that child. We also know, apart from the ion channel aspect of this, that in terms of the connectivity, because we've talked about there can be changes in inhibition, excitation, which predispose to epilepsy, but connectivity is also important as well. So functional connectivity can be different between those who respond to ethosuximide and those who don't. And so that's just another hint, as it were, as to the complexity of the mechanisms underlying childhood absence epilepsy. So in terms of the future, how do we see treatment going ahead? Identification, I think, will certainly remain clinical in terms of the history, the examination in the office, with neurophysiology support, particularly for EEG patterns. However, in terms of the actual treatment, we really need to have a good handle of the underlying genetics to precisely define the cause and therefore tailor treatment accordingly. I hope you found that useful. If you have, please do help support the channel by hitting that subscribe button down below. You're welcome to ask any questions that you want. Please do remember though that I can't answer personal questions, individual questions as it were, in terms of what treatment is the right one for yourself or for your child. I just can't do that. But if it's a broad question, then I'd be very happy to try and answer it down below. Looking forward to seeing you in the next video. All the very best.